All right, so welcome everybody. Good morning. I thank you for joining our primary care primer on housing insecurity in children CME webinar for our first steps improving child health and housing project. My name is Tim Herring. I'm the coordinator for health equity initiatives at ICAP. And I'm just going to take you through a couple of quick housekeeping measures before we get started here. So every attendee is automatically muted right now, and we ask that you remain muted until the end. When you have question and answers with any time remaining. Any questions you have also could be entered in the chat function here on Zoom. This webinar will be recorded and we'll post it and send out the link and the dates following the presentation. And then we'll also send out and post the PowerPoint as well. So any resources hyperlinked in there, you'll be able to access that way. And lastly, we will be sending out a short evaluation via SurveyMonkey that you need to complete in order to receive CME credit. Moving forward in our presentation, here first quickly is our CME accreditation statement, followed by our planning group and reviewers. Also, as mentioned previously, this webinar will be recorded and posted on our website later. And lastly, there are no commercial disclosures or conflicts of interest to disclose with our presenters. So with that, I will go ahead and pass to our chair, Dr. Marquita Moore, to discuss the learning objectives.
Hi guys, I am Dr. Marquita Moore. I'm a pediatrician with Advocate Children's Medical Group. So for our learning objectives, one is to review definitions and prevalence of homelessness and housing insecurity in Chicago, to identify and implement screening tools to sensitively screen children and families for housing insecurity, develop skills and specific clinical guidelines and best practices for delivery of care to families experiencing housing insecurity, apply resources available for children and families experiencing homelessness, and to implement ICAP housing referral tool into practice. And we would do this through 6 parts: by an overview, and then cultural sensitivity, child welfare, patient communication, clinical guidelines, and referral options with the tool. Now we'll have the overview.
Good morning, everyone. My name is Jonna Lowe. I'm a senior program manager with Corporation for Supportive Housing. I'm happy to be with you all today and hope to provide new information to you all about the housing and homeless system in Chicago. Next slide, please. The housing and homeless system is a huge entity in Chicago, and unfortunately, we don't have enough time to cover all the details of these systems. We do hope to provide some understanding of various terms, a brief history, and the interconnectedness of the relationships of all these systems in Chicago. We hope to provide clarity on specific terms and how not all entities have the same definitions, a glimpse into the needs and scope in our city, how not all communities are affected the same by the issues of homelessness, and get into some resources. We're going to now move into definitions. In the housing and homeless sector, sometimes terms are very similar, the same, but have different criteria or can mean different things to different groups. We have heard terms like housing insecurity, unstable housing, literal or street homelessness, doubled up, and couch surfing. 2 things to take into consideration. If a person isn't listed on a particular lease, they could be experiencing or at risk of experiencing housing insecurity. The other thing is that we want to take judgment and prejudice out of our speech. Move away from calling people homeless. A particular period of time, especially a very vulnerable one, shouldn't define us. Try to utilize person-first speech. Move away from phrases like that homeless family or that homeless man, and try to replace it with people experiencing homelessness or families experiencing housing instability. Next slide, please. Here are the definitions of homelessness from the U.S. Department of Housing and Urban Development. Note, we are defining homelessness and housing insecurity by their federal definitions, which include imminent risk of homelessness as housing insecurity. HUD's Homeless Emergency Assistance and Rapid Transition to Housing Act in 2009, known as the HEART Act, streamlines HUD's homeless grant programs by consolidating the supportive housing, shelter plus care, single room occupancy grant programs into one grant program through the community, in our case, the Chicago's Continuum of Care. Next slide, please. Children and youth experiencing homelessness have a different definition than adults. Entities like schools and service providers that focus on children look at things through a different lens. When you see what we see if how federal programs that serve children, youth, and families define homelessness for youth and children. Next slide, please. So we would love to believe that everyone who needs support will get it in a timely fashion. The reality is that funding and supports for people in need don't always match up to the need in many communities, especially a big complex city like Chicago. Next slide, please. So in Illinois, 8 out of 10,000 people are experiencing homelessness. In Chicago, that number changes to 21.8 of those 10,000 people are experiencing homelessness. The data that you see comes from the Chicago's Point in Time Count report. Every year, communities conduct a point in time count to collect data on sheltered and unsheltered people experiencing homelessness on a single night in January. The report for Chicago is produced by the Department of Family and Support Services and the UIC Center for Neighborhood and Community Improvement. HUD defines sheltered homeless persons as adults, children, and unoccupied children who, on the night of the count, are living in shelters for those experiencing homelessness. This includes all beds dedicated to use for homeless persons that are reported by our continuum of care in their housing inventory count, including dedicated beds located in emergency shelters, domestic violence shelters, any hotel, motel, or apartment voucher arrangements paid by public or private agencies because a person or family is experiencing homelessness. Safe havens, transitional housings, including rapid rehousing demonstration programs are all included in that count. Despite making up only 1/3 of the city's Chicago's population, the Black or African American representation remains high for those sheltered and unsheltered populations. While in the city, whites comprise 25.4% of the sheltered population and 22.5% of the unsheltered. We see how that number is very different for the African Americans in this city. Percentage slightly decreases when we think about those who are unsheltered. This study also examines that within our continuum of care, we see that about 1,300 families utilize the services from our city. But if we look at the amount of families that reported from our school system that they are in need of access to services or in need of services, we see how that number is dramatically different than those that actually access the service. Next slide, please. The reality of Chicago and the homeless sector have realities that were not created overnight. The next few slides, we're going to highlight some of those historical issues in the nation and in Chicago. In order to understand the current American dynamics of the homeless sector, we must factor in historical context. These particular events have built upon each other historically and have had ultimately left people of color disadvantaged and without sustainable resources. Institutionalized racism created policies to ensure people of color were not able to accumulate wealth and have the same access to resources as white counterparts. Next slide, please. All these structures created a very convoluted and distressing reality for people of color, comprising a disproportionate rate in the homeless system. These intentional governmental policies and embedding of structural racism carries an impact in the realities of today's state of homelessness and housing insecurities. Next slide, please. We understand that Chicago's segregation is rooted in formal housing policies like redlining that provide implicit and blatant discrimination and prejudice reinforced by public and private sectors. And this is the map of Chicago that shows the great amount of segregation that we experience in this city. Next slide, please. At this point, we are going to talk about the next section in the presentation.
Hi guys, it's me again, Dr. Moore. So we're going to talk about practice site and physician cultural sensitivity. So next is our learning objectives. So we are going to identify steps needed to create a welcoming healthcare practice site and apply physician and provider cultural sensitivity for housing insecure population. Now, why is cultural sensitivity needed? Well, it ensures care is unbiased, it aids in creating trust and leads to ideal outcomes, because having an inviting and non-judgmental atmosphere can foster trust, which can open communication, and that can increase chance of optimum with better health outcomes. Next slide, please. For cultural sensitivity, we'll start with the staffing, diversity and inclusion. To have staff that resembles that population that you're serving can help break down tension by just having them see a familiar face, excuse me. And also it is important to have translators too, because even if mom brought a friend or like the oldest child, a translator still, they still let mom have the control. And it's important to assign staff to perform ongoing competency training and to adapt services and atmosphere that can meet culturally unique needs. So it is best if you could have a staff member that can help the patient navigate healthcare system, even if you're short-staffed or you might not have a social worker or a caseworker, but having just a person in mind that you can say, help this family by scheduling their specialist visits or their imaging visits, that would be helpful. Also, if you can maintain current pamphlets and resources in the waiting area or in the exam rooms for transportation services or assistant programs, employment opportunities, or even having like a cooling site pamphlet also. Next slide, please. Scheduling. Giving priority is key because sometimes they don't have transportation, so they might arrive at like lunchtime, which is not ideal, but if we can like accommodate them, that would be great. And if phone access is limited, try to have like a walk-in policy, whether it's first thing in the morning or to try to have same day slots, because this can promote continuity of care. And when possible, try to see all children in the same household, because again, transportation is limited. Next slide, please. So for physicians and providers, treat each visit like it's the last. Comprehensive visits, that is key. Even if the lab is closed, if there's anybody there that can draw blood, that would be great. And this is also where the staff navigator helps a lot. And as physicians, we should also ask and screen for social determinants. And we should also try to create a bond and trust through effective communication by understanding that there's a range of health literacy, by not making assumptions, and by emphasizing their strengths, and by maintaining empathy and providing trauma responsive care, because being homeless is traumatic in itself. And we have to recognize that communication may be limited. So if we can get consent to leave a detailed message on the provided phone numbers, that would be great. And to also have a resource sheet, because if you already have a compiled list, then that can save time and it can also help them. And we have to understand that their housing situation can change how the treatment plan might be applied, because compliance will be higher if you can have the simplest treatment that have less doses and for a shortest course. And if possible, especially now with the pandemic, if we could have a phone follow-up instead of an office follow-up, we should try to provide that. So the AAP also has recommendations. They would like for us to facilitate enrollment of eligible children in Medicaid, become familiar with management of chronic diseases in homeless populations, optimize health visits, that's the comprehensive care, to connect families to community resources, to identify the underlying causes of homelessness, and to assist in development of shelter-based care. So in summary, cultural sensitivity is key to providing unbiased care. It allows housing insecure patients to feel welcomed and understood, which creates trust. And achieving cultural sensitivity is a constant process that requires empathy and concrete policy level action. Now, to implement this into practice, we should institute ongoing competency training for all staff, compile a list of resources to distribute to patients, promote flexible scheduling as a priority for children and families experiencing housing insecurity, implement trauma-responsive care, and designate staff for follow-up and for navigation. And if you need more information on how to provide trauma-responsive care, the AAP has a trauma toolbox for primary care. Next, we will have child welfare.
Hello, I'm Margie Scotolero. I am a child abuse pediatrician at Rush University in Chicago. I also serve as the medical director for the Illinois Department of Children and Family Services. And today I'm going to talk a little bit about welfare reporting issues related to families with housing insecurity. So why is this an issue when we're looking at housing insecurity, to talk about child welfare reporting? These two issues come together because of a number of common risk factors that exist in families facing homelessness and those involved in child maltreatment. While maltreatment occurs in all areas of society, all income levels, all racial and ethnic groups, we know that there is a higher risk of child maltreatment in parents suffering from isolation, stress, mental health issues, and substance use disorders. These problems are often occurring in circumstances of poverty and housing insecurity as well. And it's also important for us as pediatricians to be aware of our own racial biases and understand the disparities that face families, both that are experiencing housing risks as well as involved in child abuse and neglect. So we need to be very aware of our own biases when facing these issues. So all of us as medical providers, there we go, sorry. So all of us as medical providers are required to report abuse and neglect as mandated reporters under the Abused and Neglected Child Reporting Act, or ANCRA. And this requires us to report when we have reasonable belief that a child may be abused or neglected who are under our care, under our professional designations. So while we are required by law as mandated reporters to report neglect, anyone in society, of course, should report neglect. And the flip side of that is that we as mandated reporters are legally required to report abuse or neglect in our roles as professionals and caregivers to children, but this does not legally carry over into our private lives. So we are not mandated to report if we see something happen in the grocery store, for example, though certainly as a citizen, we certainly are encouraged and I would argue ethically obligated to report abuse wherever it is experienced. So I'm going to focus a bit more on neglect, since that's an issue that comes up more in working with families with housing insecurity rather than physical abuse. But we need to think about what the definitions of neglect are. Certainly, we think of child neglect as children who are not provided adequate food, clothing, shelter, or medical treatment. But there also are some other situations that will fall under this definition, including inadequate supervision. So this may be a child who's left unsupervised for extended periods of time, which leaves the child in a dangerous situation. Or if a child is placed in an environment which is injurious. So a child that's living in a home without heat, electricity, running water for extended periods of time. The important part of the neglect definition is to understand that blatant disregard is something that is strongly considered when looking into issues of neglect. Blatant disregard is defined as a situation where real, significant, or imminent risk of harm would be so obvious to a reasonable parent or caretaker that it's unlikely that that caretaker would have exposed the child to that danger without exercising precautionary measures to protect the child from harm. So obviously not every caretaker can protect child from any harm, but there are reasonable steps that any caretaker would take to protect their child. What are some of the common questions that we as child protection pediatricians face when it comes to maltreatment laws? Often the question of corporal punishment is raised. And while we within the American Academy of Pediatrics do not encourage corporal punishment, this is not illegal under ANCRA laws, but there is listed under ANCRA excessive corporal punishment as a form of physical abuse, but this is not clearly defined under ANCRA. But it is commonly accepted that if corporal punishment leads to bruises, other types of injury, if it falls under categories of cruel or unusual type punishment, that those things certainly would be considered child abuse. Is failure to attend school neglect? Failure to attend school is not covered under the purview of ANCRA. The school system is required to ensure that children of school age are attending school and can take measures within the legal system to require parents to comply with that, but that's not a DCFS reporting issue. When is it that inadequate food, clothing, or shelter reaches the level of neglect, as opposed to when a family is suffering from poverty? And I think what we really need to do is go back to that definition of blatant disregard. So certainly being a family that's suffering in poverty is not neglect, but what steps has the parent made in order to help protect their child? Have they sought additional services? Have they accepted other services that are available to their child? And so that's going to be very important for us as providers to help provide those supports to protect children and families. Is failure to vaccinate medical neglect? Well, we all, I'm sure, care for families that decline vaccines, and while we would encourage them to vaccinate their child, this is not a reportable issue or considered medical neglect. Certainly if a child is not brought for medical care, whether it's not seeking preventative care for extended periods of time, not taking a child in for care when they're significantly ill or have serious injury, these all would fall under medical neglect. And when in the course of a family that is experiencing issues of non-adherence to medical advice, when do failed appointments or failure to provide prescription medication reach that threshold of medical neglect? And we as providers need to see, are there corrective services, supports that we can put in place to help a family reach the minimal acceptable needs for their child as far as their medical care. And if this is an ongoing problem, is this leaving the child at imminent risk? So, there may not be the ideal medical care in many situations, but if we're reaching enough of the medical care to keep the child safe, then that may be still with under less than the threshold for medical neglect. So in working with families, often these barriers to accessing care that were mentioned earlier are the issues that we can provide supports and help a family. So first and foremost, in my experience working with families living in family shelters, is a fear of a child welfare report or fear of judgment when seeking medical care. So I met families who were afraid to schedule an appointment for their child because they knew they were behind on vaccines, and they were afraid that the physician would be judgmental or would make a report to Child Protective Services. So we need to be supportive and make it very clear that we're here to help the family, and that we are not judging them, and certainly are not looking to cause problems for their family. Does the caregiver have physical or mental health issues that we can provide referrals or supports to the family so that the caregiver can safely care for their child? And in many situations, this is something that can happen to keep the family together and serve the whole family unit. Is health literacy a challenge? And so it is very important to us as pediatricians to make sure that what we are teaching our families about the care of their children is understood. So asking what method of learning does the parent prefer? Do they prefer written information, verbal information, et cetera? And then to ask the parent to explain back to us what we have taught to them to ensure that they're understanding what we're saying. You know, parents will often just agree and say, yes, yes, I understand, but may not fully be taking away what we perceive that they are. Transportation, as mentioned, has been a really challenging issue for our families, and there are lots of services available to us to make sure that we can provide transportation to visits to alleviate that barrier. Child care can be very challenging to parents who have multiple children, especially if they have a child who is chronically ill that they need to make multiple appointments, but do not have childcare for the other children. It's important for us to accept that parents bring siblings to appointments to make sure that if we're providing transportation will be able to take the entire family to the visits, and provide support so that if we need to see the parent and the child individually, that someone else is available within our office to supervise siblings to make sure that the visit is supportive to the family. Flexible scheduling, as mentioned before, is really important to make sure that we have allowances for families that might come late because of the issues in transportation, to make sure that we have hours outside of business hours. If a parent is working at a minimum wage job, they may not have the ability to take time off to come to our appointments to make sure that we have appointments that are available in the hours that they can join us. And then communication, as we know, housing, families facing housing insecurity may frequently have a phone number that changes, certainly addresses that change. So to make sure with every encounter that we are making sure we have a correct phone number, updating addresses, asking for ways to reach them if their phone number or address should change. Next slide. So in summary, poverty is not maltreatment, and in the majority of cases, providing support services and removing barriers to healthcare is often the best path to improve the health of children without stable housing. But we as mandated reporters need to understand that in some situations, a child welfare report may be necessary and can also provide needed supports to a family in crisis, and that those reports do not, in most situations, do not result in a child being separated from the parent or caregiver. All right, so next in our presentation, we're moving on to patient communication and identification of risk.
Dr. Belden? Dr. Belden, you're still muted.
Hi, how are you? I lost the screen where I could unmute myself. Sorry about that. So I'm Barbara Bailden. I'm the retired head of primary care at Lurie Children's Hospital, and I'll be discussing patient communication and identification of risk. Next, please. This module aims to support people to address housing insecurity, one of the social determinants of health in your practice, and specifically to develop skills for identifying families with housing insecurity and supporting family-centered communication with this population. And I'll be following this four-part outline for this section. And first we'll discuss culturally sensitive screening, including and bringing up some of the points which have been touched on in prior sections about communication and cultural sensitivity. So screening in a primary care office, next slide, makes sense. They're major points of contact for families, especially before young children enter school. And the medical home promoted by the American Academy of Pediatrics and others includes screening as a part of the comprehensive care concept. The AAP has specifically created a policy to support this type of social determinant screening. But if we hope to do this effectively, a sensitive approach is essential. These subjects are often so difficult for families to disclose. Several common barriers to disclosure make asking, "Are you homeless?" both ineffective and possibly upsetting to answer. Many families feel shamed, fearing others will judge them and treat them less well. Parents may worry about being perceived as neglectful, triggering DCFS report, as Dr. Scotolaro mentioned. People may not think of themselves as homeless if they live with friends or families. Giving an address does not rule out housing insecurity. It may not even be theirs. And as we screen, as Margie started mentioning, we really need to be aware of health literacy challenges. There's a much higher risk in this group since poverty is a known risk factor. And we can address this by having those oral or written communications at lower grade levels, emphasizing key points, using plain language and checking understanding. As Margie said, teach back, is that technique of having patients or parents repeat back specifically in their own words the plan you've agreed on. So an example is asking a parent to tell you the name of a medicine, how much and when they'll give it. Two key concepts for this technique are normalizing teach back by saying you ask everyone, and also taking the responsibility on yourself for any lack of understanding. And further, supporting families who wish help from a case manager or another staff member while they go through the visit can really help them. Next, please. But if we hope to, excuse me, are we on the next slide?
Yes.
Okay. And the other thing is that because asking may recreate feelings of prior institutional judgment and families may worry about consequences of disclosure, we introduce screening in ways that allow families to feel more comfortable and more likely to share information. It's really important to explain why we're asking. So this would include, again, normalizing, saying we ask everyone, letting them know we ask so that we in the medical home can support families, and explaining that pediatricians cover all parts of life, even seemingly non-medical, because they can all affect a child's health. And it's really crucial we tell them what we're going to do with that information. Remember, again, as we can't emphasize this enough, many parents are concerned about DCFS taking their children away. And so emphasizing the support and resources we can provide is key. Next, please. If your practice is not currently screening for housing insecurity, carefully thinking through the process and making practical decisions about the best way to screen in your office will lead to a more successful intervention. You know your setting best and what will work for you. Some practical considerations, if you're thinking of implementing this, is do you do the screening face-to-face or on paper? Evidence suggests people may disclose more when filling out a form, but some prefer face-to-face, as we found out by interviewing parents in a qualitative study. Practices that screen choose different ages to do it. How frequently is it feasible for you to screen? Who will actually ask in your setting? It may work for a medical assistant or nurse, but tailor it to your workflow. The important point is Whoever does it needs to be trained and feel comfortable asking. And ensuring confidentiality is key. Is there adequate privacy in your waiting room, or is this better in an exam room? And everyone agrees for screening to be sensitive and effective. Oh, sorry, next slide, please. Everyone agrees for screening to be sensitive and effective, there needs to be a response that has been planned before you start. We'll discuss resources in another section, but I want to underline here the level of response depends on your setting. Arvind Garg, a researcher in social determinants of health, wrote an article emphasizing the importance of making sure one responds. And that is really true, but doesn't mean that you cannot screen until you can solve someone's situation. It's important to at least connect to resources, but empathetic listening can itself be a response. Next, please. It's also important to include the entire team. Each practice has different resources. You may even have a front desk clerk or medical assistant who can be a champion. If you're lucky, you may have social service support, either within your practice or community health workers trained to support families specifically in this area. And while the medical home can identify issues and initiate responses and provide support, it's likely that other community organizations, those listed here, will need to continue the process. Next, please. Obviously, each family situation will determine the specific resources needed. One simple action for a medical home to take is to post a coordinated entry system in the waiting room or exam rooms, or staff can hand it out. You can also help keep resources on hand for special groups such as victims of domestic violence, as well as resources that may alleviate the many other needs of these families, which I think was mentioned before. Next, please. Now, there are specific screening methods. So an obvious decision is the choice of a screen if you're going to implement this process. And I'm only going to mention a few of the validated choices available. Some ask about risk of homelessness. An example is the We Care, which Arvind Garg developed. Others ask about current homelessness. It ends up being positive for an array of situations, living in a shelter, motel, temporary or transitional living situation, or just having no steady place to sleep at night. And others ask about the history of homelessness. So in this example here, since the child was born. Next, please. Still, other choices are part of larger screens which some practices can implement. These would include the Social Determinants of Health screen developed by the Center for Medicare and Medicaid Services, which includes housing questions about both risk and current situation. Or, next please, you may be familiar with Prepare, which also screens for risk and current housing status. And all of these screens have advantages and disadvantages, how likely they may be to accurately identify families with housing insecurity, how long they take, whether they fit into your workflow, but you do have multiple possibilities to choose from. Next, please. So now let's talk about some barriers to effectively communicate for this population, and I'll explore a bit more in depth some of the topics that were already mentioned. Next, please. So for families in your practice that have housing insecurity, there are many barriers to maintaining appropriate communication and follow-up. Once you begin screening, you may even uncover reasons some families have not been adherent in the past. So barriers to effective communication include fear, as Margie mentioned, and you may be calling for medical reasons, but they may not wish to be found due to concerns about either DCFS or immigration or some other reason. These families are likely to be moving around, leading to interruptions in communication and access, often having poor access to a phone. So as well, they may be addressing multiple competing needs. They may need to go meet about public aid, housing, or food support at the same time as a planned visit. And shelters also frequently have restrictions about exit and entry or leaving children in the center, which make it difficult for parents to adhere to plans. And then frequently, due to their circumstances, they've had little experience with a medical home that supports and prioritizes continuity of care, or even with the health system in general. Many are used to emergency departments as their point of care. Next, please. So Some ways to address these challenges have been used with some success. As Margie said, as for all people, ask the address and phone information at each visit. Try to always get a second phone number, or secondary contacts can be helpful, so the family may have a person at one of the places they go who, with permission, can get or give information to them. Texting or emailing may work. Libraries, for instance, which hopefully will be open again soon, have public use computers. You can encourage families to set up email, but please remember to consider HIPAA concerns and only text or email non-HIPAA information. Many health systems have patient portals as an option, although low-income groups are less likely to use them. And finally, mail is another possibility. Find out where they can receive mail. Next, please. So these communication barriers can lead to issues with follow-up. Some I and others have mentioned. Next, please. But some other considerations that can help overcome these barriers are checking on transportation barriers, providing vouchers as necessary, trying to be as flexible as possible, as people have mentioned, with appointment times, realizing they may not have the freedom to come at certain hours. And a few practices actually go to meet them where they are at shelters where they're staying. This obviously involves creating a relationship with the shelter. So which of these modifications your practice will be able to institute will depend on your population, your staff, and your resources. Next, please. So in summary, in this section, we've shared that we can help families by screening for housing insecurity in a culturally sensitive way if interventions are offered. There are specific screens which assess for different levels of housing insecurity, and communication and follow-up of patients with housing insecurity requires enhanced efforts to make sure they can be reached and they can access services. Next, please. So as you work towards identifying and supporting families with housing insecurity in your practice, hopefully this section will help you to create a process for assessing and identifying families at risk of housing insecurity. Consider flexibility in scheduling as a priority for these children and families, and explore all possible avenues of communication. Next, please. So the next section is about clinical guidelines. Next, please. So here I am again, Barbara Bailden. I'm going to be sharing this session discussing the clinical guidelines for families with housing insecurity, which will go into some things at more depth. In this section, we hope to support pediatricians in their practices. Sorry, next, please. Develop an understanding of clinical topics related to the impact of housing insecurity on families with young children, and develop skills in specific clinical guidelines of care and best practice for this population. Next, please. This outline will guide the discussion. Next, please. So the clinical impacts on children and their families faced with housing insecurity are wide-ranging. They include impacts in the areas of physiologic, mental or brain health, and social health. Next, please. In the physiologic realm, families challenged by housing insecurity have many reasons to be at risk of either under or inappropriate nutrition, leading to malnutrition, stunting, or paradoxically obesity. They may skip meals, worry about food, and consume foods with low nutritional quality and high fat content. They're also at increased risk of multiple infectious diseases and infestations due to both living in group settings, where they have increased exposure while also having poor nutritional status. These include respiratory infections, including tuberculosis, gastrointestinal and dermatologic diseases, and infestations such as scabies or lice. Dental caries, one of the most prevalent pediatric public health issues, is also more frequent. And their chronic diseases are often unstable, partly due to challenges to adherence. For example, both the prevalence and severity of asthma are markedly increased among homeless children. And these children also suffer from higher rates of accidents and injuries than low-income children with homes. Next, please. Due to both the effects of housing insecurity on their parents, as well as direct effects on the children, there are well-documented impacts in the area of brain health. Emotional distress and often behavior problems, developmental delays, and decreased academic achievement are all more common in this population. Even in preschool children, there's increased prevalence of developmental delay, and in school-age children, homeless children scored lower on both math and reading achievement tests than other low-income students. The mechanisms through which this operates are multifactorial, including factors such as parenting challenges due to stress and increased risk of abuse, exposure to violence, and psychological trauma. Next, please. Social health is almost always impacted. Social disruption leads to many challenges, with the family support structure often damaged or totally disconnected. Homeless children often experience interrupted education, which can additionally impact their school performance. In a recent study of elementary school children, 2/3 of the cities surveyed reported that shelters need to turn away families with children because of lack of available appropriate beds, necessitating frequent moves. And these changes in location can also lead to disruption in benefits and present new transportation barriers to an established clinic. In addition, the increased rates of mental conditions and other health impairments that place families at risk of housing insecurity also may affect the rest of the child's environment and the family's ability to cope. Domestic violence, for instance, is reported at higher rates in these families and is often actually the trigger for them becoming homeless in the first place. Next, please. So following are some best practices that can optimize care for children with housing insecurity. Next, please. These best practices take into account the health risks associated with housing insecurity I just outlined and mitigate them where possible. First, fragmented health care, reliance on the emergency department as a primary care source, and low health literacy can all complicate history taking in general. Routine screening on intake, making a note of frequent address changes, or a history of scattered care provision is important. Some specific history elements to cover related to housing insecurity impacts are inquiring about specific eating behaviors and patterns, food security and barriers to healthy diet, such as no refrigeration, sleep hygiene and safety. These may be affected in temporary housing due to lack of access to safe sleep places, especially for infants. And dental hygiene and prior history of appointments. Toothbrushing may not be able to be a priority. Foods may not be healthy, and while a dental home is recommended by 12 months, this is infrequently achieved due to barriers to appointments. Next, please. And safeguarding and supervision. This is challenging in shelters and when living temporarily in other people's homes. There's both a lack of control over the environment and frequent moves to places that may not have been safeguarded. Also, due to increased risk of infection, it's really important to specifically inquire about symptoms, including skin rashes. And due to known barriers to adherence, checking on chronic conditions and assessing understanding and obstacles to following the management plan is crucial. Next, please. Developmental assessment, including surveillance and screening, is a key part of all pediatric health maintenance. But with childhood adverse experiences leading to increased developmental delay, it requires special attention in this group. It's so important, I cover it under history, physical exam, and screening sections. Eliciting parent concerns is enhanced by observation of the child in the exam room, as well as the parent-child interaction, which give rich information. And we also strongly endorse formal screens such as ages and stages questionnaire. For children 2 and over, doing a social emotional assessment, again with a tool such as ages and stages or PEDS, is useful. Other parts of the history that can help you support families and try to prevent developmental delay include daycare and school history, as well as interruptions, and family history of maternal depression and disabilities, which might alter the stimulation in their environment. Next, please. Because social factors are so important for health outcomes, taking a detailed social history is always appropriate. This includes topics such as family structure and support, domestic violence, and parental drug and substance use challenges, of course, in a very sensitive way. Prior housing, interruptions in care, employment as appropriate, and then those transportation and communication issues. Also, interruptions of benefits, so SNAP and WIC, which are both nutrition support programs, TANF, which many think of as public aid, and legal assistance. And again, consider asking about all adverse childhood experiences if you're prepared to address them, but that last part is very important. Next, please. A comprehensive physical exam is a given for all, but targeted elements to emphasize in this population include ensuring documentation of addressing either weight for length at less than 2 years or BMI for those over 2, and head circumference. A blood pressure for those 3 and over or at younger age if there are risk factors. And again, I want to underline the focused observation on behavior and development in the clinic setting. A dental application, an application of fluoride varnish is important. This is one of the U.S. Preventive Services Task Force evidence-based recommended practices, actually. Careful evaluation for infectious diseases or infestation, and a careful dermatologic exam. Next, please. And there are also specific screens to consider for all children with housing insecurity, and certainly to do for those that are actually homeless. Due to nutritional risks and living in different places, a CBC should be done for all, and lead should be done on all children less than 7, not just a lead risk assessment. Tuberculosis screening if living in a shelter, quantiferin gold being preferred for those 2 and over if you feel you can obtain enough blood. Now, if doing a PPD, this requires a return which may be problematic for these families, so you could try to arrange the PPD reading by a certified person such as a nurse at the shelter as a solution. And again, decide which social, emotional, and developmental screens you will use and complete an MCHAT at 18 and 24 months. Checking vaccine records is pivotal. There are often gaps in care and missed immunizations, while at the same time exposure is likely increased in the settings such as shelters. iCare, the state vaccine registry, is very useful, although unfortunately it still is sometimes missing information. And there are several screens out there for specific chronic illnesses, such as the asthma control test or the Vanderbilt for ADHD or the Down screening schedule. Next, please. A major issue for adherence can be environmental constraints. To create an effective management plan for these children, one finds out things, for instance, for medicines. Is there a place to refrigerate or safely store them? Do they have access to electricity for modalities that require power, such as asthma nebulizers? What is the family's access to basic needs, such as kitchens and bathrooms? Or do they have privacy? This is often an issue in shelters which have dorm-style living situations. And will you be able to contact them? Again, to follow up effectively, it's necessary to understand barriers to communication and possible changes in the living situation. Next, please. Pediatricians can also be positive supports by promoting resilience in these challenging situations, both in the medical home and through resources. So Reach Out and Read is one of the best evidence-based interventions we have in our settings. For those who haven't heard of it, it's a national literacy program. In Illinois, it's an Illinois Chapter AAP initiative and already exists in 120 practices in the state. If you're interested in learning more, you can contact Cindy Ogren, Director of Reach Out and Read at ICAP, and we'll have that contact for you. Counseling and with a focus on the 7 C's of resilience, which I put here, and focusing on supporting positive parenting can provide needed support. There are also multiple parenting programs out there, although attending them can be challenging for these families. Examples are Nurturing Parenting, Triple P, The Incredible Years. And when we identify developmental and social delays, connecting to early intervention for children less than 3 and school-based intervention after that is an important action. All ages, starting at birth actually, are eligible for the same Child Find initial evaluation services. For those less than 3, home-based evaluations have been preferred pre-COVID, but even in this group of young children, it may be easier for these families to go to a child find center. Throughout the city of Chicago, there are locations with regularly scheduled monthly hours. Next, please. Referring to concrete community resources, as has been mentioned before, can be a start to improving the family situation and access to care. Addressing disruption in benefits, such as Medicaid or others I've listed, and referring to legal assistance may address some challenges. And helping with those transportation barriers and supporting Medicaid applications as suggested by the AAP can improve access to care. Finally, to decrease lapses in school attendance, one can refer them to the Chicago Public Schools Students in Temporary Living Situations program. Next, please. And as I think it was Margie started discussing, modifying our model of care delivery can ease some of the significant barriers these families have accessing medical care. We can optimize our acute visits by providing comprehensive care as well when possible at the same time. Create a process to identify underlying causes of homelessness, in specific families in order to facilitate connection to appropriate resources. And always partner with families to develop realistic care plans that address barriers posed by homelessness, such as the transportation, communication, or no refrigeration. Remember, a plan is only good if it's feasible. Next, please. A couple of administrative issues to consider when thinking of this group. There's a code for homelessness that we can add to the record, Z59.0. And in the electronic health record, we can use the term no fixed address instead of homelessness to decrease stigma. Or put a specific flag in the chart of frequent users so we can address possible social issues such as housing insecurity when they come in. Next, please. So in summary, housing insecurity places families at increased risk for poor outcomes and poorly controlled chronic disease. We therefore need to screen these children for specific issues related to housing insecurity in physiologic, mental or brain health, and social realms. And management of problems needs to account for challenges and frequently requires community partnership. Next, please. Some concrete steps to take to optimize encounters for children with housing insecurity are: create a template or guide to support the clinical encounter for children with housing insecurity, adjust management to incorporate challenges faced by these families, and compile lists of resources by topic to distribute to patients, as well as help Medicaid enrollment to increase access to care. Next, please. So in the next section, we will discuss referral options and tools.
Thanks so much. So this is Jonna Lowe coming back. And I'm going to co-present with Dr. Luo about the referral options and tools. Next slide, please. By increasing your knowledge of the housing systems, we hope you can make referrals for your patients and children and join the ICAP and the housing advocacy efforts. Next slide, please. In this section, we will cover a high-level overview of the housing system, various housing interventions, referral options, and a few case studies. Next slide, please. Here, we will discuss a high-level summary of the housing and crisis systems in Chicago. Communities have crisis systems that include shelters, domestic violence and human trafficking resources, and homeless prevention resources. We will talk about how to make referrals to crisis systems later in this section. Coordinated entry tries to get the most vulnerable individuals into the limited housing resources that our community has available. It is a relatively new and that patients may not be in the systems so that you can really make a difference in helping the patients. And so here the visual shows the coordinated entry process. So unfortunately, it is not a quick process. Like I mentioned, the goal of coordinated entry is to match the most vulnerable individuals and families with the limited amount of resources we have in our Chicago system. Most vulnerable families and individuals are people that have complex challenges and barriers, including those of their children or the head of the household with a disability. And then individuals must complete an assessment in order to get connected to the housing resources. And so that first step is engagement. Individuals or households may often engage at emergency entities like shelters. Access to coordinated entry can happen over the phone, especially now in the sort of realities of the pandemic we're living in. And they can also be conducted in person. Sometimes people are connected to alternative resources outside the system if it's appropriate, like connecting them with stable supports like diversion or the one-time financial support. The second step is where households complete the assessment. Households are then prioritized in our system based on the assessment results. Next, those households are then households that are the highest priorities get matched to the most appropriate intervention based on need and availability. And then those households are then matched with support service staff to help them navigate the process and support their needs when it's appropriate. Things like getting an ID, proof of income, medical records, things of this nature. And then finally, families and individuals are then housed and provided supports to keep them stably housed long-term. Usually this is the social work and case management supports come in. Next slide, please. So within the Chicago's coordinated entry system, it tries to connect, as I mentioned, those most vulnerable families with the limited resources in our community. So this shows a list of the various housing resources and interventions that happen. We're not going to go through these, but based on those assessment results and sort of the level of barriers and needs of a family or individual, depends on which housing intervention they're matched through or to within our coordinated entry system. Next slide, please. And so this section reviews the different interventions that we just talked about. We're not going to go into them in a lot of depth, but hopefully give you a high level understanding and the eligibility requirements. So unfortunately, housing is not like entitlement systems. Just because someone is eligible doesn't mean that they will be able to access it. The need for housing is significantly greater than the supply. The goal of prevention is to keep households out of the homeless system, for households where short-term resources or immediate problem solving can supplement existing incomes or resources. Rapid rehousing are usually offered where the supports needed can be or should be somewhat more than a one-time thing, but also not a long-term or permanent need. Next slide, please. Subsidized affordable is when a stipend or payment entity supports the affordability for households. The goal is that households don't have to pay over 30% of their income for rent. These resources aren't usually just waiting for utilization. The need is usually higher than the demand, as I mentioned. Next slide, please. Supportive housing is affordable housing paired with supportive services to assist individuals and families in achieving goals, maintaining long-term stability. Households that have someone in their household with a disability and low or no income are usually the baseline criteria for supportive housing. This intervention is ideal for families that need additional support services long-term. Next slide, please. So this section will discuss how to refer those in these particular housing interventions. Healthcare providers who do and do not have care coordination or referral support can focus on sharing the text to connect flyer. By texting the number on the flyer, the family can get connected to the correct entry point for support. Chicago's 311 number is also a great way to connect to supports like prevention, diversion, and access to the coordinated entry system. Next slide, please. So this is a screenshot of that actual handout. It can be available electronically, and as was mentioned earlier, we really encourage healthcare providers and clinics to post and have this flyer available in their offices. In order to be utilized as a supportive entity, it will require more attention, compassion, and time. There is a need to push past the assumptions that we take for granted when we are living in stable housing. Next slide. Getting connected to shelters in the city and the suburbs are through different systems. For the suburbs, use the website to find a shelter that works best for families, for the family's location. And then if you're in Chicago, you see where those Chicago-ran shelter entities are listed there. Next slide, please. For families impacted by domestic violence or human trafficking, ensure they are connected to the appropriate hotline. And so for refugee families, we also have supports where they can get connected through resettlement services. Next slide, please. We also like to talk about supports related to the veterans community. And so the VA hospital or Veterans Affairs Hospital is a great resource for veterans and veteran families. And then, there are particular resources that would support children that are connected to veterans in this country. Next slide, please. As discussed previously, there are short-term resources meant to help a family stay out of the homeless system. And so there are very different ways to connect to those diversion services between the city and the county. So just, sort of highlighting what makes sense for the family if they're connected to the Chicago area or the surrounding suburban Cook area. For Chicago homeless families, or for families that are experiencing homelessness in Chicago, they need to be connected to supportive housing, healthcare provider staff. They can call the call center directly. They must be, or those particular staff or healthcare provider staff must be with the patient. And this is not for everyone who is in need of immediate shelter. And so it talks about the eligibility when you're connecting families to those referral entities. And then for Cook County, those families experiencing homelessness, they need to be connected through these particular resources. I'm pretty sure the eligibility is the same. Yes, it is. The eligibility is the same, but it's just making sure that different supports are for different communities. Families might also need to be connected to affordable housing entities. The hardship is, if you are connecting families to these affordable housing entities, expect those long wait lists or even for wait lists to not even be open, unfortunately. It's best to utilize those websites to find those possible referrals or what the wait times are, or if wait lists are even open. And so there's a particular program with the Chicago Housing Authority called the Housing Choice Voucher. It used to be called Section 8, or most people still refer to it as Section 8. And that's when a subsidy is attached to the household and they can find an apartment to work with the landlord. And then when we think about other services related to our city's affordable housing list, that link is provided there, as well as a statewide link as well. Next slide, please. Of course, we want to highlight the Head Start and Early Head Start programs. You can see the eligibility and the importance it offers families experiencing homelessness, as they are a priority within these two programs. And so you see the links. We have links that we can include that are hyperlinks on the actual slide. And then there is assistance to children in pre-K through 12th grade and their families through this, and I think it was mentioned earlier, through the Chicago Students in Temporary Living Situations. This program was to protect the educational rights of children that are currently experiencing homelessness and or housing insecurities. And if they need assistance, they can call 773-553-2242, but that link would provide that number as well. And then families can receive supports for immediate school enrollment, transportation, tutoring, school fees and supplies, free school meals, and even low cost or free medical referrals. Next slide, please. In our vulnerable times of the pandemic, and sort of working with families that are experiencing insecurities, we also have and want to make sure that we provide information about free cell phone services. And then because having a phone is really paramount when we're talking about supporting folks in general and the continuity of services, but also in the social distancing realities that we have. So there is a link to that free cell phone program, and as well as the eligibility on the screen too. And then this slide shows legal services that are offered to either free or very low costs when it can be appropriate for families or individuals to sort of represent themselves. And so this is more of like an advisory space, but they can also give referrals to appropriate legal aid agencies where they can support folks in a more direct way. And there are various types of situations that they can refer or either support folks that are needing legal services and advice. Next slide, please. Thank you. It's also important for parents of children with disabilities that might qualify for disability income. And so criteria for children is separate from the adult criteria, and families will likely need assistance and advocacy from the physicians in the healthcare sector in order to gain access to these disability income benefits. Next slide. So yes, we are going to move into the referral tool at this time.
Hi, everyone. Thanks so much for being here. My name is Stephanie. I'm a pediatric resident at the University of Chicago. I'm going to be talking about the ICAP housing referral tool for the Chicago area. We're going to work through this kind of with a series of case studies to let everyone work through the tool. So the first case study that we're going to go through is as follows. So you are Dr. Hastings in this case, and your patient is Bianca. So her mother, Ms. Johnson, has brought her 8-year-old daughter, Bianca, in for a school physical. During the visit, Dr. Hastings conducts the social determinants of health screening. And as part of this, Ms. Johnson shares that she and Bianca are in an unsafe living situation currently. Ms. Johnson is experiencing intimate partner violence and needs some support to leave. She doesn't have any family who can help her right now. So we're going to use the tool to kind of talk about what should Dr. Hastings do and what resources can she share with this particular family. So first, for anyone who isn't familiar with the tool, I'm just going to kind of walk through this. Basically, the goal of this housing tool is to allow everyone to kind of quickly access a lot of this fabulous information that we've been talking about through this webinar. And we've designed it as kind of a clinical pathway. So hopefully this will look familiar to folks. So you start at the left-hand side of the tool, and it's a quick way to look for if folks are eligible for any specific programs, or if they, and then based on acuity of what their needs are, whether they need something urgently or they need help with housing, but on a more long-term basis. This kind of classifies the various resources that you've just heard about. So I'll give everyone a moment to kind of look through this. And then if you can kind of look through the pathway and think about what you might be able to assist this family with and what resources would be best for them. And then feel free to put any responses in the chat. We'll give everybody about a minute just to familiarize yourself with the tool and look through the possible resources for this family. All right, perfect. So if we want to go to the next slide. So working through this tool, you see the families come in with housing concerns, and then you can go through some of these initial screening questions to see if there are specific scenarios where they would qualify for additional resources. So in this first case, just keeping it simple, identifying that there is domestic or intimate partner violence at hand. Of course, from a clinical standpoint, assessing for safety and kind of seeing if other resources are needed, but then recognizing that along this middle kind of teal column that this family would qualify for additional services through the Illinois Domestic Violence Hotline, and the hotline as well as the website are listed right there in the tool. And then similarly, you could still move down through the black and gray pathway here to see where they are currently. And, if the family identifies that this really is a extremely unsafe situation and they're really hoping to get out tonight, then there would be some sort of more short-term immediate options through the red part of the pathway for a shelter, depending on where they live. But if not, then you could also provide some of the resources through the orange or the green pathways to help them get connected, in addition to the intimate partner violence specific resources. So give everyone a second to look at that. That's it. All right, and then I think we can move on to case 2, unless anyone has any questions. Feel free to throw those into the chat. So in study number 2, Mr. Jones is bringing in his 2 children, Maria, who's 2, and Derek, who's 4, into the clinic for just routine checkups. And during the visit, Dr. Hastings, which is you in this case, again, does a great job of conducting a social determinants of health screening. And as part of this, Mr. Jones shares that they've actually been staying with his sister in Chicago for the past 3 weeks, and he and his kids have to be out of her place in the next 5 days. She's really not able to accommodate them for any longer, and Mr. Jones doesn't know where they're going to be staying. So in this case, what do you think Dr. Hastings should do? What resources can she share with this family? And we'll go back to the tool. We'll again give everybody just about a minute to look through the tool and identify a couple of resources that you think you might provide for this family. All right, hopefully everybody has had a chance to look through and decide on a couple of options. If we can go to the next slide. Okay, perfect. For this family, there are a couple of options depending on kind of how firm this 5-day deadline is, and talking through if there are any additional resources. But definitely, given that it's a pretty short time frame, it would be difficult for them to get into alternate housing. You definitely want to make sure that they're aware about the 311 resource for the Chicago area to get transportation to a shelter in the next couple of evenings. And then, once that has been set in place, they can also go through the connectmenow.org or that text line to get connected with additional resources. And hopefully between these two, kind of have a bridge for a short-term and a long-term plan. Give everyone a second to look through how we got there. Perfect. And then if we want to go on to the next slide. So I think the goal, of today's talk is really to provide a lot of the overview and the education on understanding, how to take care of patients experiencing housing insecurity and what resources are available in the Chicago area. If you, like me, have trouble keeping all of that straight in your head, then the goal of the tool is to really be a quick reference that you can easily access. And at my site, we have that kind of printed out and available in the physician workroom. And that's something that we've also made available on the Illinois AAP or ICAP website. At this link here, you can just go to the first step section of the website. And that's also where you can access these slides from this presentation for the rest of the resources in more detail that aren't included. As part of this project, we're also developing patient handouts for each type of resource in English and Spanish, as well as electronic health record smart phrases. So if that's something that you or your practice might be interested in, please do reach out to us and let us know. And we're also very happy to get feedback on the tool to make it as user-friendly and useful as possible.
Stephanie, so we do have one question right now. Are these resources available 24/7, 365 days? Just like 311 is.
Yeah, perfect. Some of the, I think if we want to go back to the previous slide. So, and I'm sure Jonna has additional information as well. Yeah, but the ones that for sure are 24/7, 311, and then most of the hotlines are either available or have a messaging service so that they can get back to you first thing in the morning. I believe the DV hotline and the VA hotline are 24/7, but Refugee One is business hours only. And then for the website and the text link, that's essentially a chatbot. So it's available 24/7, but some of the resources will require connecting with a specific person who may not be available 24/7. So that's kind of helpful for planning.
Okay, the next question is about that people with disability are eligible for supportive housing through coordinated entry system. And how is that defined? I think Jonna would have more information about that.
Yeah, so it's kind of difficult to get into the criteria of sort of each type of intervention, because it's not as though someone can sort of come into the system and say, I need supportive housing, where's my unit? It's more of the assessment I mentioned. And so oftentimes we see, particularly what you all talked about regarding how families feel in the space of, talking about hardships, being honest about those things. And so supportive housing is particularly for families with a disability. The disability could be for the head of the household. It could also be the children in the family. And that we sort of use the, federal government or HUD's definition of disability. We didn't include that in our presentation, but I'm very sure it's the same exact definition of disability that is, in the healthcare space. And so, but I think the point to make is that, sometimes head of households and even the children may not necessarily have that diagnosis as a disability, but by way of the supports and the assessment staff, they may, allude to things. And so it's not as cut and dry as, here's my disability letter, where's my access to supportive housing? Because a family could not have yet gone through that, disability step with their physicians. And so, we oftentimes talk about housing as a foundation in order to receive other services. And so I hope that was helpful.
Yes, and for the previous question earlier, can you comment on unaccompanied minors who are living on the streets in Chicago that are recommended for the referral processes?
Yeah, so, and that was a really great question, Denise. So unaccompanied minors actually have a different allocation of funding in the city. Just like I went through there's resources specific to veterans, right? So there's specific resources that are available to those unaccompanied youth or minors. And that they can access those supports through the same sort of mechanism, but they would be routed to those youth services. And then particularly our youth providers that work with those unaccompanied youth have a very high level of support and training, and that niche around supporting those youth that identify as LGBTQIA.
Great. Do we have any other questions?
Hi, this is Denise Cunil again. Thank you for that response, and thank you so much for this presentation. Regarding unaccompanied minors living on the street, do we have any statistics within Cook County or Chicago proper as to where they are? I know they're very transient, but are they isolated to one area more than the other, etc.? If someone could comment on that. And how many are we speaking of, especially now during the pandemic?
I absolutely, there are. I don't have that information, right here. I wish I would have included it because I think for us in this presentation, the focus was on younger children. But if there's a particular, want or request around those data points, we can absolutely talk to folks within Department of Family and Support Services to receive that information. Sorry, I don't have it right now.
Yeah, I'd love a follow-up on that, specifically regarding Cook County. But if you just have Chicago proper, I'd appreciate that as well.
Okay. So one source that I just located from Project Fair Chicago, they estimate about 15,000 youth experience homelessness each year in Chicago. And it's a disproportionate rate of LGBT. About 40% is about LGBT.
Thank you so much for that. I'm sorry, my dog's gonna start barking.
Okay. Do we have any other questions? Well, we truly appreciate everybody's time, and we are grateful for you guys' participation. And this is our list of contributors and our partners who we are also thankful for, and the project funding. Thank you, guys.